Today we're going to talk about the fetal urogenital system, which is chapter 64 in your book. Again, there's a lot of embryology that is involved in the first couple of weeks of development with the urogenital system. I'm not going to be going over that in our lecture too much today, although I want you to read about it. One of the main things I want you to take away from the embryology and development is that the urinary system and the genital system develop from the same intermediate mesoderm. So, what that really means is if you can remember back into your OB1, when there is some kind of uterine defect or anomaly, you have a really high chance of something also being wrong with the kidneys. Let's say you have um, a agenesis of the uterus. There's no uterus. You have a really high chance of one of the kidneys also be missing, just because they develop together. If one thing doesn't develop correctly, have a high chance of something else not developing correctly. And so that's what I really want you to take away from the embryology and development. So the sex of the fetus, of course, is determined at the time of fertilization. It doesn't develop later. And the reason that we can think of that is because of the chromosomes. They are developed right at the time of fertilization. So you either have an XX or an XY. But there's really no morphological indication of gender until the 7th week of development. Early embryogenesis shows similar development in both sexes. They kind of look the same until probably around 10 weeks. The gonads are derived from the gonadal ridges and are first parts of the genital system to develop. There's 3 sets of excretory organs that develop in embryo: the pronephros, the mesonephros, and the metanephros. Um, Only the third set remains as the permanent kidney. So there's 3 different, if you will, like kidneys, but only the third set remains as the permanent kidneys. Again, this happens so early on, like 5-6 weeks gestation. The permanent kidneys, which are the metanephros, begin to develop early in the 5th week, while the mesonephros are still developing. And they pretty much take over even in like later first trimester. So urine formation begins toward the end of the first trimester, around 11th to 12th week, and continues actively through the fetal life. In my pregnancies, I was always so encouraged and excited when I saw the fetal bladder, because that meant that there is at least one kidney. And as we continue to study, one of the things that you can't come back from is a very severe either polycystic kidney disease or renal agenesis, because the baby cannot survive. And the reason is, we come back to this multiple times, the amniotic fluid. If the fetal lungs cannot develop correctly from the amniotic fluid, then the baby is just not going to be able to survive. So seeing a bladder is such a good sign that at least one of the kidneys is developing correctly. And you can see this around 11th to 12th week. The urine is excreted into the amniotic cavity and is the major part of the amniotic fluid. So the kidneys do not need to function in utero because the placenta eliminates waste from the fetal blood. But they do filter through the amniotic fluid. The kidneys must be able to assume their waste excretion after birth. So they got to take over. The ureteric bud gives rise to the ureter, renal pelvis, calyces, and collecting tubules. And the collecting tubules are derived from the I don't know if I can say it, ureteric bud, and the major and minor calyces develop from these collecting tubules. Try to say that. It's kind of difficult. But those all develop together. So with the development of the kidneys, they initially lie very close together in the pelvis, and they gradually migrate into the abdomen and become separate from one another. Normally complete migration by 9th week of gestation. And I feel like you probably can get more of a grasp of the kidneys because you guys studied them in your abdomen class. So if you remember, if they lie close together in the pelvis, have you ever thought about like a pelvic kidney? Well, what happens is one of the kidneys doesn't rise to the occasion and go to the retroperitoneal like it should and stays in the pelvis. So that's why that happens. So here they are when they're little. There's little kidneys, and then they grow, they extend, 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 and then they go up around 8 weeks. Hey, one kidney may remain in the pelvic cavity while others migrates into the posterior flank of the abdomen. With sonography, identification of a pelvic kidney may be seen with adequate bladder dilatation. May appear as female mass and females as pelvic mass. So, like when I'm looking at the kidneys and I don't see one, I don't just assume that it's just not there. Um, I go and I look at the pelvis area, and more like 50% of the time, I'll see a kidney in the pelvis. So the kidneys are evaluated by assessing their anatomy, texture, and size. With transvaginal ultrasound, the fetal kidneys have been documented as early as 9 weeks gestation. By 12 weeks of gestation, 86% of the fetal kidneys may be imaged, and the fetal kidneys and bladder are seen by 13 weeks of gestation. They are kind of difficult to see in young sonographers' eyes because they're just a little bit more hypoechoic than the rest of the abdomen. So, what I want you guys to do when you're evaluating the kidneys is put some blood flow on there. Because if you remember, the renal arteries are coming off the aorta. If you see two renal arteries going into the kidneys, it rules out that there is possibly one kidney missing. They appear as bilateral hypercoic structures in the paravertebral regions. At approximately 15 weeks of gestation, overall echogenicity will decrease. Renal pelvises may be seen as sonolucent areas within the central kidney. As fetal age advances, fat deposits in the paranephric and sinus regions become visible. So it does get easier to see the kidneys later on. Now, when we start identifying the kidney, stomach, bladder in a couple of weeks, I'll be able to show you what the kidneys look like on ultrasound. And sometimes they're easy to see the further along you get, but at 20 weeks, when we do the anatomy screen, they can kind of be difficult to see. Between 18 and 20 weeks of gestation, the kidneys are slightly hypercoic compared to the surrounding tissues, and by 25 weeks, it is possible to distinguish the renal cortex from the medulla, outline the renal capsule clearly, and see a central echogenic area in the renal sinus. So you're also going to, of course, assess the bladder. You'll see the kidneys, the collecting system, and fetal gender. That's what you're looking for with the urogenital system. Usually you won't see a ureter unless one of them is dilated. Here they are, here's those kidneys, and they're in the back. So how I really like to visualize the kidneys is I will do a transverse abdomen. I'll try to get the spine on top. This is the transverse spine. This is showing the bladder, which you guys have been able to identify already, the stomach and the heart. We've also been able to look at the 3 vessel cord with the 2 umbilical arteries coming across the bladder. Here's another image. Sagittally, just like you would in one of you guys, um, later on, it's sometimes easier to see them the kidneys sagittally. So if you're having trouble seeing them in a transverse view, you could turn and put the baby in like a long position and look retroperitoneal to see both of the kidneys that way. Now, I know that you guys have learned a little bit about dilatation of the renal pelvises in your abdomen class, and the same thing can happen in um, a fetus. And a lot of the times, this a little bit of fluid in the renal pelvis is normal, but you do want to note it, however, because it can be a soft marker for Down syndrome or chromosomal abnormality. But most of the time, it's just a normal thing. It seems to happen more in males. So again, what I said, the normal fetal ureters are usually not seen. The normal fetal bladder should always be seen. If you don't see the fetal bladder, that's a problem. The ureters are typically less than 1 to 2 millimeters in diameter and should not be filled with anechoic fluid. If you do see a snake-like area within the lower abdomen going to the bladder, follow it up to the kidney, and it's concerned that there might be some kind of obstruction. You can also see urine jets, but sometimes that's a little bit difficult. And urethra is usually not identifiable in a normal fetus. So the bladder is imaged as a rounded echo-free area centrally located in the pelvis. There's no specific bladder measurement, but you kind of just look for filling and emptying. If the bladder is not seen or appears too large, you reevaluate it at the end of the exam. If it's considerably large, filling the lower pelvis, and it doesn't seem to empty, I would note that in your exam because that could be a cause from obstruction. If you don't see the fetal bladder at first, I would go and do the rest of your exam and then come back at the end to see if you see it. Most of the time, in between your 30 minutes that's going to take to do your exam, the bladder will fill, just kind of like the stomach. If we've talked about that a little bit before too. The normal fetal bladder wall should be thin, and the normal measurement of the wall is 2 millimeters or less, and it's best measured at the umbilical, at the level of the umbilical artery. We do not measure the bladder wall unless we think that it looks thick. Determination of fetal gender should be documented with presence of other abnormalities or in case in which external organ does not meet sonographic criteria for male or female. So here's the deal. A lot of people don't want to know what they're having. They want to do at all right now. It seems to be another trend beyond the gender reveal is now people are just flat out not going to find out. So what I usually do is the trick of the trade is I try not to find out either until the very end because I don't want to put it in my head if it's a boy or a girl because I don't want to accidentally say he or she during the exam. So at the end of the exam, I always do look and I tell them to turn around and look because I do want to look and make sure the genitalia looks normal because there are reasons why it could appear ambiguous, I guess. Um, so I definitely always do check and take an image. They don't need to know that. And by the end of the exam, I can pretty much not say anything, will myself not to say anything. But you always want to just check no matter what. The other thing is it's extremely important that we use specific sonographic criteria when determining gender. If we just don't see a penis and a scrotum, that doesn't mean that it's a girl. I mean, the legs could be crossed and hide in the little boy parts. So you want to make sure that those legs are wide open and you're doing specific sonographic criteria. In the majority of the fetuses, the external genitalia can be differentiated in the second trimester. I would say 18 to 20 weeks. Sometimes, like I've said before, little girls, little labia are kind of, I guess, swollen around 14 to 18 weeks, and they can kind of almost appear as possibly boy parts. Um, and so that makes it kind of difficult sometimes to determine exactly if it's a girl or a boy. So I like to wait till 20 weeks. That seems to go down at that time. And you'll see either the 3 lines, the hamburger sign, or the turtle sign. Sometimes you just can't miss boy parts, though. To be honest, sometimes those little guys are just spread wide open, and anybody, trained or not, could see that it's a boy. Girls seem to be a little bit harder, but seeing the visualization of the labia um, is usually a good indication. The 3 lines. In the second trimester, identification of the female fetus should only be determined when the major and minor labia are seen. Male fetus in the second trimester determined by visualization of penis, scrotal sac, known as the turtle sign. And testes not visible within the scrotal sac until approximately 28 weeks gestation. So here is a little booty. So when we're looking at the genitalia, it's kind of like one of our models had said, a baby sitting on a copy printer, and you're just looking up at their boot. But so here's the bottom. These three little lines are labia. The legs are pretty open, so you can see that there's definitely nothing else. And you can see like the little lips of the labia. Here's another image. Here's a little cute booty. And then these are definitely the labia here. With the boy part, it's going to definitely be more like a turtle. So the scrotum and the little penis there, little turtle head. And this is a 3D image of that. The amniotic fluid is a critical marker and assessment of renal function. The fetal kidneys begin to excrete urine after 11th week, but do not become major contributor of fetal urine until 14 to 16 weeks of pregnancy. Observation of normal amniotic fluid volume before this time will not exclude possibility of renal agenesis. So sonographic findings suggesting abnormalities of the urogenital system, dilatation of any component of the urinary tract. So we're talking dilatation of the kidney, dilatation of the ureter, dilatation of the bladder, dilatation of their urethra, appearance of hydronephrosis. You guys know what that is. A renal cyst, enlarged echogenic kidneys, no kidneys seen, no bladder seen, anechoic tortuous pelvic mass, dilated urethra, abnormal amniotic fluid volume. Those should all hint you off that there could be a problem. So this is a dilated kidney here, and kind of looks like what you would see hydronephrosis in a just an adult too. You can follow, in this case, the ureter here. So you know that the blockage is not just at the kidney, at the uropelvic junction, but more at the probably ureter vesicle junction. When you see like a snake-like anechoic area going into the bladder, it's a indication definitely for a dilated ureter. When there is a blockage in the urethra, what you're going to get is more of a keyhole sign. So you're going to have a huge dilated bladder, and you're also going to have fluid within the urethra because there's a blockage there. Renal malformation may be divided into two categories. So there's congenital malformations, and then there's obstructive processes. And we're going to learn a little bit about both of those today. You remember horseshoe kidney, cake kidney? There's an obstruction here, double collecting system, a pelvic kidney, a polycystic kidney. There's a lot of things that can go wrong with the kidneys. The recognition of the urinary tract anomaly is of significant clinical concern because several fetal conditions incompatible with life. So kidneys always scare me. They almost scare me more than a heart. I feel like with the heart, a lot of this stuff can be treated with surgery, but if there are no kidneys, there's nothing they can do. Or if the kidneys are polycystic, there's nothing they can do. And so it makes me really nervous. Kidneys probably scare me the most out of it. Everything else can potentially be treatable, but not having kidneys, that you just can't do anything about that. So here's some renal abnormalities that we're going to go through. Renal agenesis is pretty easy to, think of that. One of the kidneys or both the kidneys are multicystic renal dysplasia. You're going to want to know that. Congenital hydronephrosis, renal duplication, pelvic kidney, horseshoe kidney, infantile polycystic kidney disease is going to be a huge one. Adult polycystic kidney disease we'll learn a little bit about, and Michael-Gruber syndrome. The big ones that I want you to know that are going to be on your registry are the multicystic and the infantile polycystic. So renal agenesis is the complete absence of kidneys. Condition occurs when the ureteric buds fail to develop or when they degenerate before they can induce the metanephric mesoderm to form nephrons. The prognosis is dependent on unilateral or bilateral. So in diagnosing the renal agenesis, acquiring complete clinical history and thorough examination of all fetal structures is critical. So there's going to be a couple things that are just going to hint you off about this. There's not going to be as much fluid or any fluid, or it's going to be anhydramnios, which is absolutely no fluid. That should be your first hint that something's going on with the kidneys, or something. So you're also not going to see a bladder. So clinical history should include documentation of possible cocaine use or maternal diabetes. Those seem to be correlated with the renal agenesis. Bilateral renal agenesis is a lethal disorder due to the renal insufficiency and hypoplasia of lungs. I want you to know that. I want you to know why it's lethal. It's because there's renal insufficiency and the hypoplasia of lungs. Why is there going to be hypoplasia of lungs? Because there's no amniotic fluid. I know I've stressed this to you so much, but it's just so important that you understand why the lack of amniotic fluid is pretty much lethal. In case of a unilateral agenesis, presence at least one functioning kidney contributes to excellent survival rates, just like in adults. I had a friend who just donated a kidney. She's able to survive without one kidney. So bilateral renal agenesis is lethal. Unilateral agenesis is excellent. Prognosis. The bilateral renal agenesis is often referred to as Potter syndrome. This is another thing I want you to know. What Potter syndrome means, it's like multiple things, is Potter's facies, which is you'll have a flat nose, a recessed chin, abnormal ears, and wide set eyes. And the reason that occurs is because there's no amniotic fluid to develop, let the cute little profile develop. Like we've seen in all of our scans, we've seen these gorgeous little profiles of these babies. And the reason is because that amniotic fluid just gives that buffer to let the face develop correctly. And when there's no amniotic fluid, they're pressed against the uterus, and that makes the nose flatter and the chin more recessed. The ears are odd and the wide set eyes. They also could have malpositioned limbs for the same reason. So the sonographic findings, you're going to see severe oligohydramnios after 15 weeks of gestation. And why 15 weeks? Because the babies could have normal fluid in the first trimester because the placenta is taking care of a lot of the amniotic fluid. The next thing you're going to look at is persistent absence of the urine in the fetal bladder. You want to observe it for your entire scan. You know, you'll go back and look and go back and look, but you start thinking, okay, this kid has no fluid. I can't see the kidneys. I'm probably not going to see a bladder because there's no kidneys. So the failure to visualize kidneys or renal arteries. If I'm thinking, well, you know, maybe I'm just not seeing the kidneys, I always put on the blood flow. And if I don't see renal arteries, that confirms to me that there's no kidneys. The other thing you're going to see is a very abnormally small thorax. And the reason you're going to see that is because of the lung hypoplasia. So this is showing unilateral renal agenesis. I can't see this kidney. I can see this kidney. I can see one kidney here. This is, looks like bilateral. Now you remember the adrenal glands are right on top of the kidneys, and I feel like sometimes those can look like kidneys, but you won't see the renal arteries going into them. Here is another image of that. I like to get like a transvert or like a coronal view here and see the aorta, and then I'll put color flow on, and usually you'll see both of those renal arteries coming out. If I don't see that, it's very concerning that there's a bilateral renal agenesis. Here is what I'm talking about here. This sonographer looked like this, couldn't see him. She put the aorta, put color on the aorta. Usually you should see the renal arteries coming out there, and you don't see any. That's a telltale sign that there's no kidneys. Also, you can see that there's no fluid around this baby. So a horseshoe kidney, it forms when inferior poles of the kidney fuse while in the pelvis. The fusion may occur 1 to 4 in 1,000 births, is 2 to 3 times more common in males. It may be found as an isolated anomaly or be associated with other anomalies or syndromes. Isolated horseshoe kidneys carry a good prognosis, but often associated with other renal conditions like kidney stones, hydronephrosis. Anomalies occurring with horseshoe kidneys include central nervous system disorders, cardiac abnormalities, urogenital abnormalities. The incidence of trisomy 18 and 45X also increased. 45X is Turner syndrome. It's difficult to diagnose in utero, and that's something that's usually diagnosed later on after. Several sonographic clues that may indicate horseshoe kidney is a transverse image of fetal abdomen demonstrates abnormal lie of the kidney. If the spine is down, connecting isthmus may be seen anterior to the aorta. In sagittal or coronal views, the clear delineation of the inferior pole of the kidney not well seen. Kidneys may appear oblique. Renal ectopia. Kidneys initially lie very close together in the pelvis. They gradually migrate into the abdomen and become separated. Normally complete migration by 9th week of gestation, but in some cases, one of the kidneys may remain in the pelvic cavity while other migrates into the posterior flank of the abdomen. So it occurs when the kidneys lie outside of its normal position in the renal fossa, usually lies in the area of pelvis. Crossed ectopia occurs occasionally. Both kidneys may be fused or appear to be fused as they are located on the same side of the body, is considered a form of horseshoe kidney. So we're looking and we see one kidney in the correct spot, but we don't see the other kidney. We do not assume right away that they're missing a kidney. We go down and we look in the pelvis because they have a higher chance of having a pelvic kidney. And a lot of the times, just pretty much next to the bladder, you'll see a mass and it'll be the kidney. It'll look like a kidney. It'll be in there strange, but it'll look like it. So cross-fused ectopic kidneys lie on the opposite side of the abdomen relative to its ureteral insertion into the bladder, and the kidneys usually fuse together and found on the right side of the abdomen. Now, I don't think I've ever seen one of these before, but it would be interesting because you won't see the kidneys in the normal spot, but the fluid will be normal and the bladder will be normal. So you're thinking, okay, there has to be a kidney somewhere because the baby wouldn't be able to have the amniotic fluid in the bladder, and the lungs, the chest wouldn't be the normal size. So then you start looking around in the abdomen, and most of the time you'll find a kidney. The prognosis based on acquired complications or in association with other anomalies can have complications of dilatation or dysplasia, associated anomalies of skeletal, cardiovascular, gynecological abnormalities, or GI abnormalities. Sonography will demonstrate absence of kidney in normal position with adrenal gland filling the space of the renal fossa. The abnormally located kidney will typically be smaller and rotated obliquely or horizontally. If kidney located in the pelvis is typically found lying superior to the bladder, adjacent to the iliac wing. So this is what we'll see. I'll go down and I'll look, I'll see the bladder, and then I'll see a mass with a little bit of a renal pelvis there. And then I'll put some color on, I'll see that renal artery, and I feel like I just won the lottery because it went looking and I found something. Extrophy of the bladder is characterized by protrusion of the posterior wall of the urinary bladder. So we kind of talked about this a little bit in our abdominal wall defect chapter. It's caused by a defective closure of the inferior part of the anterior abdominal wall during the 4th week of gestation. No muscle or connective tissue forms in anterior abdominal wall to cover the urinary bladder. Therefore, the bladder is formed external to the abdominal wall. Occurs primarily in males, 1 in 30,000. I've never seen this, I don't believe. It's most likely sporadic occurrence and is isolated. They might have elevated maternal serum alpha fetal proteins, because anytime there's an opening, let's say in the, spina bifida, gastroschisis, any kind of opening within the baby, that you're going to have elevated MSA-FP. Genitalia malformations are commonly seen with this, like undescended testes, anterior displaced scrotum, small penis, cleft clitoris in females. There's going to be multiple surgical procedures required to correct the bladder abnormality, as well as other associated genital anomalies. Fluid-filled bladder, not visualized. However, normal kidneys and amniotic fluid are evident. The small irregular mass representing averted atrophied bladder, identified in the lower abdomen below the umbilical cord insertion. Sonographer should know abnormally low cord insertion when anomaly is present. So the bladder still functions, it's just outside. The sagittal view of the abdominal pelvic region of the fetus will reveal an anterior mass that appears as a mound of soft tissue. Transverse view of the pelvic bones will demonstrate widening of the iliac crest. Important to differentiate this between cloacal exstrophy, which is more of an opening within the genital issues, difficult to do in ultrasound because the bladder findings are kind of the same. But if it's just the bladder, then it's just bladder exstrophy. Cloacal exstrophy is has more of the bowel involved too. What I really want to stress to you right now is renal cystic disease, because those are going to be on your registry and I want you to know them. So there's a heterogeneous group of heritable, developmental acquired disorders. Potter's calcification or Potter sequence is used to describe diseases associated with, okay, this is going to be on your test. What classifies Potter syndrome? Renal failure, oligohydramnios, Potter facies. Those 3 things. So infantile polycystic kidney disease is autosomal recessive polycystic kidney disease. It affects both fetal kidneys and liver. So infantile polycystic kidney disease affects both kidneys. It's characterized by development of small cysts in both kidneys and liver cysts. Cysts in the kidney thought to be caused by tubular malformation or ectasia of collecting ducts. The distal collecting ducts typically affected more than proximal ducts due to their early development. The malformation results in cystic dilatation of the renal tubules measuring 1 to 2 millimeters. Instead of you seeing little cysts, what you're going to see is overall enlargement of the kidneys that are very, very, very echogenic, because they're very, very small cysts. So the formation of the cyst resulting in the tubulointerstitial damage, resulting in tubular dysfunction and fibrosis. So these little cysts have caused the kidneys not to function correctly. So normal kidney tissue has been replaced by all these little itty bitty microscopic cysts. So there's renal failure because there's not normal functioning of the kidneys. There's varying presentations include differential types, the perinatal form and the juvenile form. Perinatal form is lethal because both kidneys are affected. It occurs really early on in the pregnancy, so oligohydramnios, so lung hypoplasia, and then the baby doesn't have normal functioning kidneys. So the most severe forms are found prenatally and associated with renal failure, oligohydramnios, and absent urinary bladder. In some cases, the kidneys are so massive they fill the entire abdomen. That's another thing I want you to know is these are huge kidneys. The prognosis is dependent on the severity of the renal disease, but most fetuses diagnosed in utero will be stillborn or die early because of renal failure and lung hypoplasia. Very rare for the fetus to survive the first year of life with this. So sonographically, individual cysts not identified, instead kidneys massively enlarged because of hundreds of dilated tubules. Enlargement of kidneys may not occur until 24th week of gestation. The enlargement will lead to abdominal circumference being large, but very, very small chest. And why is that? Because of lung hypoplasia. Here is an achogenic kidney here. Enhanced renal tissue achogenicity characteristic because of multiple interfaces created by dilated cystic tubules, oligohydramnios, smaller absent bladder seen. Oligohydramnios may not be evident until 15 to 18 weeks. And why is that? Because the placenta helps with the fluid until that time. So that is infantile polycystic kidney disease. And that's what I want you to know. They're achogenic, they're large, it's bilateral, it's not good. It's mostly lethal. Multicystic dysplastic kidney disease is different. It's characterized by multiple smooth-walled, non-functioning, non-communicating cysts. So these cysts, you can see, they're going to be anechoic. They're going to be all over the kidney. Renal tissue replaced by cysts of varying size throughout the kidney. Entire kidney or only a portion of the kidney may be affected. Between cysts, the renal stroma may be present, but normal renal tissue is absent. The ureter and renal pelvis may be atretic. Renal artery may be hypoplastic or absent. It's thought to be a result of early obstruction uropathy or abnormal development of the metanephric mesoderm and ureteric bud. Affected kidney is non-functional. So it's the most common form of renal cystic disease in childhood. It's one of the most common abdominal masses in neonates. Incidence is 1 in 3,000 births, more common in males and females, and it's linked to maternal diabetes. The reason why this has a better chance of survival is because most cases are unilateral. So in unilateral multicystic dysplastic kidney disease, you have one good functioning kidney, and that's all you need. So the other kidney is cystic and not functioning. But if they are bilateral, you're going to have the same issue as the infantile polycystic kidney disease, and the baby is not going to be able to survive. It's associated with multiple abnormalities. Again, the prognosis for infants varies based on the prenatal and findings. In isolated cases of unilateral involvement, disease will regress with time and disappear. A small collection of cysts will calcified border will be present in renal fossa. In the mid-trimester ultrasound scan, fetuses with multicystic dysplastic kidney disease presents with at least one kidney demonstrating multiple cysts of varying size that may affect part or all of the kidney. Cysts typically start at the periphery and appear small. Over time, they can enlarge. Here's what it looks like. So you're able to see these cysts. They're anechoic all over the kidney. The overall size of the kidney may be enlarged, resulting in possible enlargement of the abdominal circumference, and the kidney borders are difficult to define. Yep. When bilateral, you're going to have the same thing as the infantile polycystic kidney disease. There's going to be oligohydramnios and absence of bladder. So those are the two different ones I really want you to know. So infantile, you're going to have more echogenic, large kidneys. With multicystic dysplastic kidney, you're going to have cysts that you can see all around the kidney. Infantile is bilateral most of the time. Multicystic is unilateral most of the time. So now we're going on to adult dominant polycystic kidney disease. So this doesn't happen until adult, but in the fetus, sometimes you can see that kidneys are already echogenic. So the cysts typically do not enlarge or impair renal function until adulthood. So these kids, if they have a history of polycystic kidney disease, we kind of look at the kidneys. If they're echogenic, there could be a possibility that later on in life they could have this. So the sonographic appearance is similar to autosomal recessive polycystic renal disease in that the kidney is symmetrically enlarged and echogenic. The bladder is usually present and amniotic fluid volume is normal because the kidneys are still functioning. So if you have echogenic large kidneys, but the fluid's good, bladder's good, you still want to note it because it could be adult polycystic kidney disease. So obstructive cystic dysplasia. Renal dysplasia occurs secondary to kidney obstruction in the first or second trimester of pregnancy. Long-standing obstruction leads to development of fibrosis and cystic replacement of renal tissue. So if the kidney is so dilated that you can't barely see renal tissue, you're going to have the same thing. You're going to have a non-functioning kidney. Here's some pictures. The unilateral disease can be caused by uretopelvic or ureterovesical junction obstruction. So the severe obstruction from the ureter still can cause dysplasia in the upper pole of the duplex kidney. The bilateral obstructive dysplasia caused by severe bladder outlet obstruction, usually urethral atresia or posterior urethral valves. Prognosis is dependent on if it's unilateral or bilateral. If it's unilateral, then they can survive. If it's bilateral, they have poor outcomes. Early sonographic findings may only be hydronephrosis or hydroureter. Kidney will most likely appear enlarged. Early signs of dysplasia is present of hydronephrosis or cortical cysts. And I think that's all I want you to know about that right now. We're going to go a little bit later. If the disease is bilateral and bladder outlet obstruction or the keyhole bladder may be apparent as well as severe oligohydramnios. So what I really want you to get is where the urinary tract can be obstructed at. So the junction of the ureter entering the pelvis is called the uretopelvic junction. The junction of the ureter where it enters the bladder is called the uretovesical junction, or the level of the urethra, or a megacystitis. So which one do you think is worse for a prognosis? It would definitely be the level of the urethra. And the reason why is it would be happening to both kidneys, because the urethra would be blocked, the bladder would be blocked, which would mean that both ureters are blocked and both kidneys are blocked. Usually with, like, let's say there's a blockage of one of the ureters, then one of the ureters and one of the kidneys is blocked, but the other one functioning correctly. Same with where the renal pelvis is. If there's one kidney that is blocked, but the other one is not, they have a better chance. So the higher the lower in the body the obstruction, the worse it is, if that makes sense. So once you get to the urethra, the whole system is blocked. They have the worst chance of survival. If the obstruction is early, multicystic kidney may develop. If obstruction occurs in the first or second trimester, cystic dysplasia may result. Late obstruction produces hydronephrosis. Term pelviectasis commonly used in conjunction with hydronephrosis. Pelviectasis refers to dilatation of the renal pelvis without dilatation of the calyces. Hydronephrosis refers to dilatation of the renal pelvis and the calyces. And you know that from your abdomen chapter. So hydronephrosis is the dilatation of the renal pelvis that occurs in response to a blockage of urine at some junction in the urinary system. It commonly occurs when there is obstruction in the ureter, bladder, or urethra. Is generally in result of obstruction at the lower level in the urinary tract. Fetal hydronephrosis may occur as unilateral or bilateral process, and unilateral renal hydronephrosis commonly results from obstruction at junction of the renal pelvis or ureter. Fetal hydronephrosis is most common fetal anomaly. Most common fetal anomaly. Most common fetal anomaly. Findings suggesting hydronephrosis include abnormal intrapelvic anterior to posterior diameter measurement. Here, I need you to know these. So, if you have a transverse kidney and you see a little dilatation of the renal pelvis, if it's greater than 7 millimeters, it's considered mild hydronephrosis. If it's greater 7 to 15, it's considered moderate. If it's greater than 15 millimeters, it's considered severe hydronephrosis. If measurement exceeds 1/3 of the renal diameter, follow-up should be considered. Of course, we would follow up on this. In cases of pyeliectasis is diagnosed, fetus should be carefully examined for anomalies associated with aneuploidy because mild pyeliectasis is a common feature associated with Down syndrome. So this is what I'm talking about here. This is our transverse view of the belly. We got the spine on top so we can see both transverse kidneys. This is the anterior to posterior renal pelvis measurement. This is like probably 3 millimeters and it's like 2 millimeters. So it's just very tiny, but it is a soft marker for Down syndrome. So that's why we always like to measure and tell someone in our report. But I see it all the time. And most of the time it's just totally normal. But if you had this and it was 15 millimeters, which would be probably from here to here, that would be severe hydronephrosis, and that is not good. The prognosis depends on the severity and cause. When considering severity without relating to cause or dysplasia, mild hydronephrosis has been found to resolve antenally and postnatally without surgical intervention. Sonographically, you're going to see an obstruction somewhere in the body. So here's a good image here. Well, this one has mild hydronephrosis on this side, but look how large this is. So you would measure still from here to here, and that would probably be greater than 15 millimeters, which is severe hydronephrosis. Another image seeing that it is very enlarged. You can see that the calyces are involved in this. Yeah, it's not good. Bilateral severe hydronephrosis. This is not good because there's thinning of the renal cortex. So the functioning renal tissue is probably not doing well. The uretopelvic junction obstruction, it occurs at junction between the renal pelvis and the ureter, and the results in the backup of urine into the renal pelvis and calyces. Could be because of an abnormal bend, adhesion, abnormal valve, abnormal outlet shape, absence of longitudinal muscle. The UPJ is the most common reason for hydronephrosis in neonate. It's more common in males. It's usually unilateral. Only half of the disorders are found during early childhood. Early prenatal detection may improve long-term renal function. Sonographically, collection of the anechoic urine located immediately within the renal pelvis that communicates with the calyces. The renal pelvis may take on like a bullet shape appearance surrounded by dilated or normal calyces. The renal cortex, ureter, bladder, amniotic fluid are usually normal. So here's what it looks like. You're going to see just an obstruction right when the at the pelvic junction. Dilated calyces. Commonly presents with dilatation of the lower end of the ureter in a ureterovesical junction. So it's different than what we just went over, uretopelvic. Obstruction leads to backup of urine and kidney, and you'll also see an enlarged urine-filled ureter, which is a megaureter. So you'll see that snake-like black area in the abdomen. Megaureter may result from primary ureteral defect or stenotic ureteral valve or fibrosis. It occurs secondary to obstruction at another level. In the majority of cases, the cause is the distal portion of the ureter being a peristaltic, which is primary megaureter. Under normal conditions, the constant muscular contractions of the ureter is what's responsible for moving urine from the kidney to the bladder. If the segment of the ureter is not peristalsing, it lacks ability to compress those muscles. The constant contractions are disrupted, leading to inability of the urine to be moved into the bladder at a constant normal rate. It's found to result from ectopic ureter still within the bladder, causing obstruction of the upper pole of the kidney. So more common in males. Seem like a lot of these are more common in males. A lot of the times it's unilateral. You could see a duplication of the renal collecting system. The prognosis for infants is good regardless if it is associated with refluxing ureter or non-refluxing ureter. The affected kidney visualized with anechoic dilatation of the renal pelvis and tortuous fluid-filled dilated ureter. Careful effort should be made to differentiate dilated bowel from dilated ureter. And one of the ways you can do that is to follow the kidney to the bladder. If you see the snake-like black area, black snake-looking vessel, flow from the kidney to the bladder, it rolls out a bowel. It's the ureter. Oh, and then on top of that, critically thinking skills, you will see that the kidney is also dilated. So it looks funny, but you can follow it all the way to the bladder. 3D image. If the ureter is dilated, it should appear anechoic. Bowel will have low-level echoes. The bladder and amniotic fluid is normal in cases involving one kidney. If both kidneys are affected, amniotic fluid volume may be reduced. If renal duplication identified, dilated upper renal pole is observed with normal lower pole. In cases of reflux, sonography may reveal changes in the AP diameter measurements of the renal pelvis. The other thing I want you to know is the posterior urethral valve obstruction. PUV obstruction results in hydronephrosis, hydroureters, dilatation of the bladder, and posterior urethra. This is not good because the whole urogenital system is obstructed. Occurs because a valve. It's the most common urethral anomaly. In males is the most common cause of infravesical obstruction. Obstruction causes backup of urine and bladder, ureter, and in most severe cases, the kidneys. The obstruction is apparent throughout the pregnancy. It leads to impaired renal function dysplasia. Fetal renal function may be assessed by aspirating urine from obstructed bladder. We have had a couple of these happen and the prognosis was not good. The baby was up at Children's Mercy. They aspirated the bladder some to kind of relieve some pressure, but the fluid, the amniotic fluid was just, there was barely any amniotic fluid. And so the baby just didn't have a good prognosis. So the sonographic features is severe bladder dilatation, massive hydronephrosis with diaplastic changes in renal tissue, dilated tortuous ureters, and oligohydramnios. The bladder wall will be severely thickened with a dilated posterior urethra, which is we call the keyhole sign. And this baby that we did have that had this last year, the bladder was huge and the kidneys were so large. So look, these are both AP diameters of a transverse kidney. Look how large those are. Severe hydronephrosis occurs at 15 millimeters, and look at these at 47 and 35. Severe hydronephrosis eventually leads to cystic replacement of renal tissue. All right, kidneys get more echogenic. Anterior urethral valves is a congenital defect resulting in obstruction of the anterior urethral valve in a male. The valves are located in multiple locations. Exact cause of obstruction is unclear. Degree of obstruction varies owing to the range of clinical findings. Could be bilateral hydronephrosis, end-stage renal disease, bladder rupture, dilated anechoic urethra seen proximal to the valve. Valve usually not appreciated in obstetric examinations. 3D helpful to determine extent of obstruction. Here's bilateral hydronephrosis because of that. You can see the urethra. This is the penis. The urethra is dilated. The amount of amniotic fluid present, as well as dilatation of collecting system in ureter, will vary from normal to severe. Obstruction may not be apparent until late in gestation. Prune belly syndrome. It's characterized by 3 features that I need you to know: cryptochordism, agenesis or hypoplasia of the abdominal wall muscle, and dilatation of the collecting system. It's thought to result from embryological defect of the mesoderm and urethral obstruction malformation complex. It's referred to Eagle-Barrett syndrome. It's a rare condition mostly seen in males. Association with males thought to be due to complex development of male urethra. So the prognosis depends on the renal function. With normal amniotic fluid, prognosis is typically good. Most cases associated with early obstruction will lead to renal dysplasia and hypoplasia of lungs. So all depends on the amniotic fluid. Bladder appears anechoic, large and thin-walled. Prostatic urethra in males may be enlarged, mimicking posterior urethral valve keyhole appearance. Both kidneys are hydronephrotic, and ureters are dilated and tortuous. So you have all that. You're going to have no abdominal musculature. The testes are going to be undescended. And you're just going to have a dilated urinasis. And this is what babies look like after they're born with that. They literally have been so stretched out and have no abdomen muscles that they kind of just look, their skin's all wrinkled. It's so cute though. Ureterocele is cystic dilatation of intravesical bladder segment of the distal ureter. You guys probably went over this in abdomen. They can occur some in fetuses too. So let me show you. Oh, females are more likely to present with ureterocele. Prognosis is usually good. Let me see show you what it looks like. So if you have a bladder here and you see a little cyst, it could be a ureterocele. That's all I want you to know about that for right now, since you guys kind of know what to do with that. Sometimes the ureter is also dilated and the kidneys are dilated a little bit. So renal tumors. Most common renal tumor is a mesoblastic nephroma or hematoma. You need to know that. So it looks like. Never seen one before. They're so rare. I also want you to know about what a Wilms tumor is. You can see those sometime in fetuses. It's a malignant tumor, more commonly seen in females. But there's a good prognosis if they can resect it early. So you have both kidneys here, and then you're going to see a mass. Again, I haven't seen a kidney tumor before. But you do need to know if you see a mass on the kidney that it could be a tumor. They have happened before. vascular flow. Some of the risk for tumor with different syndromes. With surgical removal of affected kidney, prognosis is excellent, which is great. Prognosis with Wilms tumor, which is malignant, is good with early resection. Polyhydramnios is typically seen with these tumors. So they're going to have enlarged, more fluid than normal. They all have a different appearance, but some are solid and cystic. I'm not going to have you know those, but I do want you to know the most common type is the hamartoma, and then there's also the Wilms tumor, which is malignant. Congenital malformations of the genital system are very rare. Sonographic team may be requested to determine gender of fetus when gender-linked disorders are considered. Hemophilia and aqueductal stenosis are two. Hydrocele occurs in male fetuses. We see these all the time where there's fluid in the scrotal sac. I don't even note it, to be honest, unless it was very, very, very large. It usually resolves after birth. Simple hydroceles appear as anechoic fluid surrounding or partially surrounding testes. Undescended testicles, gonads eventually descend from the abdomen to the pelvis. As this occurs, the diverticulum and peritoneum process, vaginalis, protrudes through the anterior abdominal wall to form the primordium of the inguinal canal. Basically, that means that the testes stay in the abdomen until the inguinal reins until 28 weeks, but you should in the third trimester see testes in the scrotum. If descent is interrupted or stopped, testes will remain located within the inguinal canal. Associated with the risk of torsion cancer. You guys know that from your abdomen class. The scrotal sac will appear void of testicular tissue. So if you see a scrotal sac but no testes in the third trimester, it might be something worth noting. They can check it after birth. Ambiguous genitalia refers to sonographic inability to delineate fetal gender. A lot of the times what happens is you either have typically like a female that has like adrenal hyperplasia, which is enlarging the genital and causing it to look more like a male, but it's not. It's just because of the hyperplasia of the adrenal glands. True hermaphroditism is a rare condition in which both ovarian and testicular tissues are present. Internal and external genitalia are variable. Most fetuses will have a normal karyotype, but some are mosaics. So they would have some female, some male cells. Again, I've never seen this. Here is like, you can kind of see the labia, but then you also see some of the penis. It's just difficult. A lot of the times what you're going to see though is this is a large clitoris from adrenal hyperplasia. So it is a female, but yet because of the hormones, it's causing the clitoris to be enlarged, looking more like a penis. Female fetuses with pseudohermaphroditism have a 46XX karyotype. Most common is adrenal hyperplasia that causes masculinization of the external genitalia. Male fetus can also occur with pseudo. They have testes, but it looks more like girl parts. That is from different syndromes too, but that doesn't occur as often. So the sonographer must be careful diagnosing ambiguous genitalia because penile and clitoral size may vary in normal fetuses. I'm telling you this. 16-week female girl, like my little baby Isla, she was difficult to tell because the labia were swollen. And for a while I was like, is it a boy or a girl? And I like a seasoned sonographer and I was struggling. So around that time, you just got to be super careful and telling people what it is. Chromosomal abnormalities associated with ambiguous genitalia include trisomy 13, triploidy, certain deletions, and translocations. Other associations include cloacal malformation or adrenogenital syndrome. Surgery may be required to repair associated abnormalities and cosmetic concerns. Sonographically, key signs to investigate for gender are absent. In many cases, abnormally small penis, hard to differentiate from a large clitoris, which we kind of talked about. So if you just are kind of seeing, don't guess, have them come back. I know they'll be disappointed, but you rather, I'll evaluate and get it right than, something be wrong and you just kind of double guessing yourself. Go. So you can see looks like maybe a penis, but then the labia there. So it's kind of difficult to see. You can also have fetal ovarian cysts. So if you see a cystic area in the lower pelvis, it's not unusual. They're usually benign and they're because of the hormones going through mom. Most common cystic mass in female fetuses range in size from small to large, usually located on one side of the abdomen or lower pelvis, can be unilateral or bilateral. So just to be aware of those. May appear anechoic or hypoechoic. If there's hemorrhage or torsion, which, I hope not in the sweet little baby, they could have more complex. But just, you're always looking for everything. There's a female genitalia, and then there's a large cyst next to the kidney. Looks like septated. There's more of a hemorrhage. All right, I think that's enough. That was a lot of information, but it's really important. So I think that's probably our hardest chapter to get through. Let me know if you have any questions.